This conference will now be recorded.
Well, good afternoon. This is kind of out of my comfort zone in that I prefer to be in person, but because of this pandemic, I thought it would be safer for me and safer for you to do this from my home. So I appreciate you all being there. And I guess if you have questions, you can ask them. However, at the end of this presentation, and you do have the slides, there's my email address and I believe my cell number. I'm Diane Wood. I used to be employed by the Oklahoma Foundation for Medical Quality. However, due to COVID, we had a layoff, um, mainly because we did a lot of contract work and we had CMP grants from the state health department. And you may have met my former colleague, you did meet my former colleague this morning, Mickey Raymond. Um, so, hey, if you know of any open positions out there, let me know. Um, Prior to working at OFMQ, I worked for Oklahoma Department of Human Services in aging services, where I had hoped to be able to retire from. But unfortunately, at the time, this was, I believe, 2015, 2016, there was a budget shortfall. And at that time, my job looked a little bit iffy. Prior to that, I worked at the Oklahoma chapter of the Alzheimer's Association, and it was an awesome experience for me. I've done case management for the Advantage program. Some of you all may be familiar with that. I worked at an adult daycare, and I worked for a hospice right out of my internship for my master's degree. So I can say that I've been very fortunate to work within the aging network and to see a little some viewpoints about aging in different arenas. So with that, we will get started. My connection with Alzheimer's disease, I do have a family connection, is a great aunt, and this particular great aunt kind of resembles this lady in the picture. She had no children. Um, she was a widow. She worked as a maid for a couple of families in Oklahoma City, and she was really very active. She didn't drive, but she used the bus to get around town, to get her groceries, to pay her bills. Very active at at our church. But we started to see a decline in her hygiene, which was very unusual for her. Um, she wore dresses all the time. She wore hose all the time. Everything was matched perfectly. It was ironed. It was pressed. Her hair was done, and we started to see this slow decline. And eventually, we had to place her in a nursing home, which was devastating for me. This was probably 1985, 1990 or so. Um, and I didn't see at the time a lot of engagement or person centered care, perhaps, with the care that she had. So I know that long term care has certainly advanced in that respect because her goal every day was to break out of the nursing home. When I say break out, I mean break out. She did that quite often. And I would get calls about her being combative um, and trying to leave. What she would do, she would hang out at the front door. She would blend in with people coming in, coming out, and she would leave. Thankfully, she didn't get very far. But what was always kind of a fear of mine was that she was very familiar with the bus routes, and there was a bus stop right across the street. I don't think she ever quite adjusted. So the more we know about this disease, not only the physical aspects of it, but the emotional needs that people have um, when they have a dementia is so important. Knowing who they are is so important. You should also have um, a 2020 Alzheimer's disease facts and figures sheet in front of you, or be able to access it at some point. And I would suggest that you go to the Alzheimer's Association site at www.alz.org and then put in the 2020 facts and figures. Every March, the Alzheimer's Association issues a special report and they update the latest facts and figures. They also include some sort of specialty topic about this disease. And it's very, very interesting. If you're into numbers, if you're into knowing more about um, the association and some of the things that they're working on. So you'll see from the sheet in front of you that Alzheimer's is the sixth leading cause of disease, of which there is no cure. So if you think about cancer, if you think about heart disease, if you think about um, chronic illnesses such as diabetes and high blood pressure, those diseases, some people have been cured or um, their disease process has been managed in some way. Right now, there is no cure for Alzheimer's disease. More than 5.8 million people in the United States are living with Alzheimer's disease. And 1 in 3 seniors dies of Alzheimer's or another dementia. And we'll talk later about the difference between Alzheimer's and dementia. Um, One thing that I think is interesting um, for you all is that, up to about, would you say, or would you agree that maybe about 40 to 70%, probably more 70% of residents in nursing homes have some sort of dementia? Um, those of you all who work in nursing homes, which I've spoken to classes over the years, seem to nod their heads in agreement that that makes up a great deal of uh, the diseases in your own community. So there's lots of really good information in the facts and figures report, and there's always information in there about um, long-term care issues. So let's talk about the definition of dementia. So we'll see later that dementia is a broad, very broad term. It's really an umbrella term. And all dementias have these basic symptoms, loss of memory being the primary factor, or other intellectual abilities serious enough to affect a person's daily life. So if you have a parent or an older loved one, and they've been, independent, doing their thing, living their life, but all of a sudden there's something really different about them. There's some sort of disruption where they can't manage what they used to do without any assistance. So it's anything with memory, intellectual abilities. That would be the ability to manage your health issues, take medicine, pay your own bills, drive to the grocery store you've been going to for years. When that kind of thing happens, and it interferes with the person's daily life, that's concerning. So Alzheimer's is the most common form of dementia. It accounts for at least 70% of all the cases. So Alzheimer's is a specific form of dementia. So the um, diagnosis of the number of people with this disease has been referred to as a tsunami. Memory loss that disrupts daily life, and again, remembering that Alzheimer's is a specific form of this disease. And it can be multiple symptoms, cognitive impairment, language, sometimes being able to find the right words, very short attention span, poor decision making, behavioral issues, and noticing maybe some falls or near falls can be some characteristics. So here's the umbrella term, and you'll see several types of dementias. Alzheimer's being the most common form, vascular dementia is about the second most common form of dementia. Lewy bodies dementia, kind of the person with Lewy bodies, they kind of mimic someone with Parkinson's disease, but it's a little different. And frontotemporal lobe dementia is very common. We'll talk a little bit more in depth about some of these specific types of dementia. So again, early symptoms: missing dates, missing appointments, not having a grasp as to what time it is, and what the day of the week is, what the day of the month is. Now, I'll tell you, I lose track of dates, especially being unemployed at this time. And I'm sure some of you all may even have to look at your telephone to figure out what the day of the month is. Familiar names, calling someone else's name, misnaming very common household items, repeatedly asking the same question over and over again, very, very common sign. Uh, Driving, getting lost. How many silver alerts have we seen recently? These are very common things that we do: banking, cooking, paying bills. My great aunt was one of the best, and I know I'm biased, but one of the best roll makers. But we noticed over time she would bring rolls like to the family dinners, and we kind of got to a point to where something's missing, and so we would have a backup plan for rolls. Things that and the roll recipe was something that she didn't have to follow. It was something that was in her head. Poor judgment, things that are out of character for a person to do. It's like um, the inhibitions are very much out front versus a person being able to control some behaviors. Mood changes, isolating. The person may know that something is wrong or different, out of sorts, and so sometimes they will isolate themselves. Attention to hygiene, very common among females. What the example I gave you earlier about my great aunt, she forgot, didn't realize that she had the same dress on, Sunday in and Sunday out, week in and week out. Bathing, didn't realize that she hadn't taken a bath. Um, and what's important to know that this is not a normal part of aging. If we all thought about it, we probably know people in their 70s, 80s, 90s, even, and a few that are 100 years old who are still independent. But this type of aging is disease related. There's something wrong. It's not normal. So let's talk about risk factors. Now, your risks do increase as you grow older. So age is a risk factor. Um, so when you look at these particular statistics, you'll see that about a third of people over the age of 85 or older do have a chance of developing some sort of dementia. So leaving that though, there's another 66% or so of people over 85 who don't have a dementia. But it's just important to know that age can be a risk factor. Another risk factor can be gender. Women, because we typically live longer, just being a female increases your chance of developing a dementia. Um, Family history. So, first degree relatives like a parent, a brother, sibling, or a child can increase your chances. Um, Risk increases if there's more than one family member. Um, Heredity, genetics, or environmental factors can also increase your chances of developing a dementia. So let's talk a little bit about genetics. Um, with genetics, there are two types of genes that can play a role, excuse me, in affecting whether a person can develop the disease. So there's a risk gene, which means you carry the gene, but the chances of developing it are fairly low. Then there is a deterministic gene that says your chances are pretty high. Sometimes people that have this gene, they will develop symptoms pretty early. However, what's to keep into consideration is that it appears in less than 5% of the people who are diagnosed. So I have known a few folks when I worked at the Alzheimer's Association, they did have this gene that runs in families. So, the question that I always wonder about is if there was a chance, would I want to know ahead of time? Would I want to know that I do indeed have this deterministic gene? Some people say yes, I'd like to know, and then some people say no, I would just much rather live my life and not place any kind of extra burden on the way I live my life. But that's all very individual. So other risk factors are head trauma, repeated hits to the head, or repeated loss of consciousness. And so there's a head and heart connection. We would say that anything that's good for the heart is good for the head. Um, so every heartbeat pumps a number of blood to your head. There's several brain cells that use at least 20% of the food and oxygen that your blood carries. So when it comes to diet, antioxidants are important. Green leafy vegetables are important. A diet that is low in fat, eating good fats can decrease your chances of developing a dementia. Vascular dementia, as I mentioned earlier, is the second most common form of dementia, and it's increased by having connections to blood pressure, heart disease, stroke, diabetes, high cholesterol. And we'll see some of that explained a little more in depth later. Race has been shown to be a risk factor. I was working at the association when part of their yearly report came out about race. And so Latinos have a 1.5 times chance of developing the disease, and African Americans are twice as likely to develop some sort of dementia. And so the sub risk factors are health. With vascular disease, both races seem to have high numbers of diabetes, high blood pressure, high cholesterol, which can easily lead to a mini stroke, or mini strokes can increase your chances of developing vascular dementia. And then socioeconomic characteristics can also increase your chances of developing diabetes, high cholesterol, and hypertension because of diet. Um, and diet might be due to poverty. Sometimes there's a lack of diagnosis, just thinking Well, when you get older, you're going to get forgetful anyway. And so, not getting a diagnosis early where medications can be a little bit more effective. Lack of access to healthcare can be an issue where you can get a diagnosis. And there are a lot of people that do still have some distrust of the medical community. So these can all be risk factors as well. I know personally, I've known several people, just one so far in my family, but several church members to develop um, Alzheimer's disease or other types of dementias. So let's talk about changes to the brain. On the left side of the slide, you'll see a healthy brain, a healthy picture of a brain rather. And then on the right side, you'll see a picture of the brain at autopsy. Um, so what happens is the cortex, the hippocampus, and ventricles in the brain are damaged. So you'll see the cortex is involved with thinking, planning, and remembering. And then there's shrinkage within the hippocampus. And the area that you see that's really kind of missing on the right side of the picture is what the area that's believed to be where memories are stored. Ventricles, you'll see that there once were fluid in that area, but now there's spaces there. And so, in thinking about those that you may have known with Alzheimer's or related dementia, they travel back in time. And so, that area that you see that's not there is that hippocampus area that's believed to be where memories are stored. My great aunt grew up, she was born in Grant County in Oklahoma, but she spent a great deal of her younger adult years in Kansas City. And so, as the disease progressed and as she tried to get out of the nursing home, where she thought she was going was where she wanted to go rather was Kansas City. That was her aim. And you know how you don't really know much about your older relatives. Um, and so, I found a little bit more about this. She's a black lady, blue haired. I don't know if any of y'all have seen older black women with blue hair. It's a way that they used years ago to help keep their hair white. Don't ask me the science behind that, but that's what I was told. But she was very much involved in our church. But people have a life when they were younger. But whatever was happening in Kansas City, she was trying to get back there, and so that was her aim. Um, I later found out too, because kind of the veil had come down, where the things that we don't talk about, that she had gotten pregnant at the age of 14 years old. The baby died in childbirth. Um, while she was being cared for at the nursing home, she had a prolapsed uterus, which can be related to difficult childbirth. So, the memories that are there from years ago, they're real. It's just that we may not, or your loved one may not always share everything. So it can be a gift and a curse, maybe, to learn more about your loved one. Um, and, it can be some very awful things that come out. In working with families, there were a few families I remember in particular. Their loved one had been sexually molested, and it was something that they had not really talked about. The family had some inkling that maybe something had gone on, but they weren't sure, and it was confirmed as the person progressed with this disease. Very, very sad. I'll tell you this one funny story. Um, there was um there was a couple at my church, and the wife, they both had they both had Alzheimer's disease, but they were still coming. And so the lady got up to make a statement, which we thought was going to be a testimony. But what she ended up saying was that 40 years ago, my husband had sexual relations with this woman, and the woman is sitting right here today in the congregation. We fell out because it may have been very true. Um, and the fact that this was where she was in the disease process. When I say we fell out in like shock, because she shared this. But it can be very much of how this disease progresses and that people's memories are very much real. Okay, I'll move on from that. So let's look at brain cells that appear under the microscope. You may have heard the term plaques and tangles. If you look at the area that's kind of some fuzziness, those are considered to be plaques, clusters of proteins. And if you look at um, the larger cluster above that, those are considered to be tangles, where the strands of proteins are also there, and the cell is dying from the inside out. You'll also see the inset picture that's of a healthy brain cells that are communicating with each other. Now, as we age, we're told that we all develop plaques and tangles. It's just that people with this disease tend to have more of them, which creates a decline in that individual, where there's communication issues, memory issues, and issues that just involve managing your life. So here's a picture of a PET scan, which is one of the better ways to diagnose um, Alzheimer's disease. But from what I understand is that PET scans are very expensive and often not covered by Medicare. PET scans, they show the metabolism of glucose within the brain. So on the left side, you'll see a picture of a normally functioning individual. The picture in the middle is someone with late Alzheimer's disease, and it shows a dramatic loss of function. The picture on the right is on of an infant at 6 months old. And the difference there is that that infant will go on to develop. They'll go on to be able to function. They'll go on to be able to form memories and to develop, intellectually. But you see the comparison between the two pictures of the late Alzheimer's person along with the infant. But what's important to remember about that is that when you're caring for somebody with Alzheimer's disease, is that they are still an adult. They're still a person. They're not a child. Um, Whereas um, their capabilities have been diminished, their ability to think has been diminished, but they have a brain disease. And so we never want to treat someone with this disease as a child. We never want to demean them and call them my baby. And, they're acting like they're just like a child. They're just functioning as a child. Well, they have a brain disease, and you have to remember that. Because those of you, again, that may have had experience with someone with this disease, sometimes just out of the blue, the person may speak. Out of the blue, um, there can be just some kind of epiphany that occurs to where they act like themselves. So just remember this is a brain disease. It is nothing to be ashamed of. When you are helping families, which you will be dealing with families quite a bit, and families can be very, very challenging. Just remembering and taking into consideration their grieving process of their loved one and helping them to understand that their mother or their father is still there. They just have a brain disease. So I'm going to just talk briefly about these characteristics of Alzheimer's disease or these different dementias. There's a lot there, but I just want to pull out some of the information. So again, it's the most common, accounts for about 70% of the dementias. Usually the hallmark of this disease is memory. Um, and that's it. We talked a little bit about plaques and tangles being the cause of this disease, and there's other information within this slide that you can refer to later. Vascular dementia, we talked about being the second most common. Hallmark of this disease is a series of many strokes due to high blood pressure, high cholesterol, diabetes. And when you think about it, some of these issues, some of this can be controlled by our, by our behavior in some ways. Um, Smoking, high cholesterol being due to diet perhaps. Sleep apnea can can cause some heart issues. So some of these causes or risk factors are pretty can be controlled. Dementia with Lewy bodies is becoming very it's growing in popularity. One thing about this type of dementia is that it can be detected by a blood test. Um, which are called Lewy bodies. Um, and the hallmark of this disease is marked by motor impairment. It kind of looks a little bit like Parkinson's in some way. Um, Another hallmark of this type of dementia is people sometimes have very vivid dreams, very visual hallucinations. So it's important to be very much aware of, of this type of dementia and the possibility of sleep disturbances. So there's a mixed dementia, which can include Alzheimer's with vascular dementia or Alzheimer's with Lewy bodies. They have a little bit of both of the dementias. Frontal temporal lobe dementia is a dementia that affects the front part of the brain, um, where behavior, where judgment is um, the is controlled, perhaps. Um, this type of dementia can be pretty interesting if you've ever cared for or know someone with this type of dementia. Their behavior is it can be very, very outrageous. Sometimes they may act out sexually. Um, if you can think of the person who is very conservative, very rigid, but then all of a sudden they are cursing, they're undressing themselves. Uh, this is this type of what this type of dementia looks like. Also, what's interesting though is that memory is spared with frontal temporal lobe. When I worked at an adult daycare, there was a man who had dementia. We'd been told that he'd been diagnosed with Pick's disease, which is the type that it affects the person completely different. So he was very very vocal. He cursed, but he could play a mean hand of dominoes. And so his ability to calculate, to know if you've ever played dominoes, to know what dominoes were still out there in somebody's hand. It was absolutely amazing to watch him, but he couldn't tell you what, he was very unclear about what was appropriate and what was not appropriate to do. Primary progressive aphasia affects a person's language skills, finding the right words. And usually, this type of dementia, the person just eventually just may not speak at all. I've known two people with this type of dementia or this type of syndrome, completely heartbreaking because one was a speech pathologist. So imagine, all of your life, and she worked with kids. She had worked with kids on how to properly develop speaking skills, and then now she began to have problems with her own language. One other lady, she had her PhD. She was a nurse practitioner, and she taught at OU. She taught other nurses, and then now she was affected with this type of dementia and could not speak herself. Parkinson's disease. Sometimes at the later stages of this disease, you will see a combination with the Parkinson's and some sort of dementia. TBI, traumatic brain injury, and CTE, chronic traumatic encephalopathy. We've heard a lot about this as it relates to sports figures, just com- just repeated blows to the head, jolts to the head, head injuries due to falls, due to accidents, becoming more and more popular. I know that when I was growing up, um, we didn't wear helmets when we wore bicycles, but pretty much now you see a lot of kids when they're learning to ride a bicycle because we've realized how important it is to protect the head, to wear a helmet, and to protect the head, period. So let's talk about tips for family and professional caregivers. These are kind of, to help manage behavior and to help with communication. Routine can be very, very important. Doing the same thing, the same way, every time, the same time of day. Answering the question the same way is so important. Now, where I stressed earlier about not treating a person with this disease as a kid, but we do know that as kids grow, that routine is important. And really, routine for all of us should be very important. For the person with some sort of dementia, it is vitally important and it can alleviate anxiety and frustration. Redirection, listening for the signs of confusion, just redirecting them if they get in this loop about what time is it? It's time to go. I got to go feed the chickens. I got to go feed the cows. Redirecting them to something to get them out of that loop, looking for other things that they may be able to do to help them get out of that loop. Or reassuring them that you're going to be there and they're safe, and also telling what's called the therapeutic fib. So, if you have to say that a loved one is on their way to get them, you use whatever you can to help redirect, uh, to help alleviate some anxiety that they may be having, to kind of get them out of, because a lot of times, if you can think about a person with this disease, they live in a state of confusion. And whatever it is that they can understand, it all needs to be activity related and all needs to be calm, creating a sense of calmness for them. Sundown syndrome. If you all, those of you all that may currently work in a home, you may notice this, that maybe about 2, 3 o'clock after lunch has been served, after blood sugars have increased some, that the confusion and agitation just kind of can go through the roof. Also, this may be the time of day where the shift change, and so they see people coming, they see people leaving, and so they want to go too. Um, and so it can be there are ways that maybe you can manage this. This is the time to have some sort of activity ready. This may be a time for them to go outside, to have some sort of physical activity. And also, it's been found that bright lights, because the sun is kind of going down, hence the name sundown, or it's getting a little darker through the day, that making sure that the lights are at the same level throughout the day, and that can help people not have any kind of visual hallucinations or think that or become very paranoid. Sounds. Um, there used to be in nursing homes the overhead paging, and so you've seen that over time go away. Um, Taking a person perhaps to Walmart that has this disease might be is not a good idea. If you're taking care of, some veterans who may have seen combat, if there's a lot of noise with slamming doors, that can all be a little disconcerting for people with this disease. So being able to manage sound, if at all possible. Refusing medications can be due to being paranoid. Are you trying to poison me? What is this for? These are too many pills. And you can't just assume that the person doesn't know what they take. You have to take that into consideration too. So perhaps telling them what the medication is. Imagine taking care of a nurse. Oh my God. Uh, that that's going to be difficult. Somebody who has some medical knowledge. So if you have to say, you have to use this therapeutic fib by saying the doctor prescribed this for your blood pressure, or your doctor prescribed this for your arthritis. Make the doctor the bad guy. Um, you know, if whoever it is that this person respects, you may have to use that individual as the bad guy in order to get the person to comply. Now, they have the right to refuse the medication. They do have that right, but it's something that you need to be very aware of. Um, Sleep, you want to watch caffeine in the afternoon. You might want to watch medications that may hamper sleep disturbances. It's been found that sleep throughout the night can reduce falls. Uh, you might want to look at incontinence supplies that may be a little more absorbent, so that you don't have to wake that resident up in the middle of the night. But then you might also, this is where the person centered care comes into play, because you might want to take into consideration what the routines were of that individual. Could this person have worked at night? You know, um, could they be a night owl? So you have to take those kinds of things into consideration too when it comes to sleep. Dementia at the table. Visual changes are something to be aware of. Putting the food items right in front of them so that they can see everything. Colored plates so that the food doesn't all blend in. So, say you have mashed potatoes, you have cauliflower, and you have a chicken breast on a white plate. Because dementia can affect all systems in the body, they may not be able to see the food. And when you think about it, we eat with our eyes. So you might want to consider looking at the color of the plate. Small amounts. Have you had residents that may say, "Oh my God, this is just too much food. It's just too much." And because they may see this large amount of food, it may be a turnoff. It may, be like, "I can't handle this." So maybe mini meals, smaller meals, maybe more often throughout the day as staff allows. Um, sometimes we are social eaters, and I know that there are some homes that allow their staff to eat with residents. Sometimes they can help with a person that's not, their appetite has decreased some because they're used to eating with people. And then, of course, providing assistance with eating. Um, Finger foods can help with a person with a low appetite. And then this is where sometimes it can be a little devastating for families to watch, their loved one being fed or at the feeder table, which I hate that phrase. Um, so, people's manners change at time with this disease. So there may be some things you have to talk with families about that, you may have to just let manners go. We're going to give them the amount of respect and allow them to keep their dignity. But as far as their manners are concerned, this is just part of this brain disease. Taste buds do change as we get older. We desire more salty, uh, flavored, well seasoned food, sweet food. So, if you have a resident that only wants to eat cake, that would be me. So keep that in mind about taste buds. Swallowing, of course, choking um, are signs and something to look for as people age because of aspiration pneumonia. Very high likelihood of residents. Um, some people in the early stages can forget to eat, which means there's weight loss, and then some can forget that they ate, which means there's weight gain. So just being aware of that. High calorie drinks, shakes, protein shakes, meals that are high in protein can be um, some tips. Bathing, oh my goodness, um, huge issue. Assessing for past traumas. I don't know if your intake assessment or any of the assessments that you do account for this. Do you know if the person drowned or near, if there was a near drowning rather, if they had some issue around water? Was there some issue? I kind of mentioned something earlier about molestation as it relates to getting undressed or someone helping you undress. With bathing, remember that it's an intimate experience, especially you're helping the person undress, you are helping them wash areas that, are private areas. What are their rituals? What are their habits? You know, do they bathe daily? Do they bathe every other day? Bathe or shower? Um, what were their habits at home? It's all in the way you present bathing or showering or personal care, whatever you call it. What if you're going into Walmart and somebody just rushes you and says, "Welcome to Walmart, we're going to take a bath." Well, no, 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 no. You've got to um, ease into this conversation. You've got to ease into making it enticing. If you have to call this time a spa day, or it's Saturday night, we're going to go take a bath. You have to make it somewhat enticing, something that they would be appealing to them. Um, Bathing can be perceived as threatening because of modesty issues, um, a loss of independence, a loss of privacy, and the fear of water can be there. And for some reason, some people with Alzheimer's or related dementia can have a fear of going down the drain. It's just kind of a thing that has been known to be there. So there needs to be some sort of reassurance. If you have a staff person, a CNA who is very patient for this particular activity, that's who you want there. I have known homes that just they use one person to help with personal care, to help with bathing. And if you're able to identify that person, that's the best thing you can. I mean, that's just great. Fear of falling as it relates to bathing, and not rushing. Not rushing can be, the issue. Remembering that bathing is not a task; it's an activity. It's a ritual. It's an experience. Make it comfortable. Um, Allow for privacy. Maybe allow the person to bathe or to wash their peritoneal area. Give them that washcloth for that. And then washing the hair separately. That might just be too much stimulation to wash the hair and to take a bath at the same time. It's an individual process. Not everybody may have issues with bathing or showering. There may be some who do. So taking into account that it's individual. So effective communication, being aware of vision and hearing issues, approaching from the front, not the back. Don't say, "Do you remember me?" Because nine times out of 10, they don't. Address them by name. Some women may not remember that they were married. They may only remember their maiden name. It's all individual. So if you were to call them by Mrs. Wood, which is my married name, I may not recognize that. It just depends on where I am in the disease process. And nonverbal communication works best. The do's of communication. So give short, one sentence explanations, repeat the instructions exactly the same way, allow time for comprehension. So this is an issue I have. I speak very fast. And even in just a normal conversation, um, I admit I have the tendency to interrupt people. So I have to work on this part and allow people to hear what I've said, to get it, and to respond. So allowing them time for what you just said. Either agree with that person or distract them. Being patient, being cheerful, and reassuring is important. And respond to the feelings rather than the words. So if you pick up that this person is anxious, uh, that they're a little fearful, respond to that feeling of fear by reassuring them that you're there for them. Don't reason, and for goodness sakes, don't argue, because you will not win an argument with somebody with dementia. If you haven't had that experience, try it. I'll tell you, you will not win. Don't confront them. Don't remind them that they forgot. Don't question recent memory. And if at all possible, if you have to leave the room and come back in later, or if you have to leave and get somebody else to come and try to help administer that medication or to perform personal care in some way, try not to get annoyed or allow them to see you get annoyed. It's something about people with this disease that they've had some losses, but they also develop kind of like I don't know, a sixth sense. They can really pick up on your emotions. And so getting annoyed with them will possibly get them annoyed at the same time, and you're not going to get anywhere. Deceased relatives. Oh my goodness. Deceased relatives. The memories that they have are real. So you have this lady who's been widowed for 30 years. Um, Maybe there's a picture of her husband in her room, or, God forbid, she has a son or daughter who's deceased in their pictures. Don't tell them that their loved one is dead if they are talking about this loved one, because they just simply don't remember that. And to tell them that their loved one has died, they're going to relive that moment all over again. Um, that's and people mean well by saying, well, now and even relatives can do this. Now Daddy died 30 years ago, Mom, and she may say he did. Nobody told me. So, just redirecting that conversation, um, saying, he called and he said he would be here pretty soon, and then redirect. Now, that's saying that may be seem cruel in some respects, but if the opposite happens where you tell them they're dead, then you're going to have that person who's grieving and asking questions about, I didn't know, and nobody told me, and when is the funeral, and all of that. Asking them, hopefully these are pleasant memories about how they met, something about their marriage, uh, and basically what they want is some sort of comforting, reassuring memory or message, because they're concerned about where their husband is. So they're concerned that they're not going to be able to leave and go feed their children. Um, Looking for the reason behind the repetitive question. Um, Turn the action into a behavior or an activity. Um, if you're able to care plan a person who might enjoy folding towels or wiping off or dusting, staying calm and being patient with the person. But activities for behaviors are so important. When you think about the fact that so if I were to for instance, I put my aunt in a nursing home, and prior to her going, she was active. She did go places. But so we have in a nursing home because she needs to care for her. She needs care that we couldn't provide in the home. But to put her there and she not have anything to do or not have any purpose, it's just it just kind of breaks down that personhood that they have. So we've got to find some sort of way to repurpose that person and give them tasks. Sometimes tasks they'll be beside bingo, or tasks beside um, some of the other things that we do. What is it that they can do that gives them that sense of who they are and who they used to be years ago? My aunt made the best rolls, I mentioned. What would have been wrong with at some point giving her some dough to play around with in a controlled, kind of a controlled activity or a controlled environment? Um, Provide an answer. Give the person the answer that they may be looking for if it's not harmful. Memory aids, clocks, calendars, photographs can be very comforting. Um, accept the behavior and work with it if it's not harmful. I want to go home. You all want to go home, don't you? So I'm trying to be very cognizant of the time, and I see it's 3:28. A lot of you all may be from out of the city, and you're thinking about this drive, and you may be thinking about what all you've got to do. So this want to go home is real for somebody with this disease. And other causes can be physical changes, unable to recognize where they are. Some of it can be depression. Some of it can be the stress is too high. If there's a lot of noise, if there's a lot of activity going around that they aren't participating in, Um, if they're bored, they want to go home. Um, so home, really, when you think about home, it's a place of comfort. It's a place where, you can be yourself with your family. Excuse me. It's a place where you can go home and just relax and, you know, take care of you. And the person that may have this disease is thinking about a place and a time where they can be comfortable. So whatever you do, have to do to make their surroundings like home or give them that sense of home, that's really what they're saying and what they need. Coping strategies, getting to the emotion behind or getting to the feeling behind the words that they're saying. Looking at photo albums, triggers, examining triggers, removing objects that may remind them of going home, removing hats, removing a coat from sight, um, and any kind of activity that involves food, music, physical activity of some sort can be a great way at redirecting. Physical health. So if a person begins to, if they're beginning to develop maybe a UTI, which you probably all know about UTIs, um, you'll see some agitation with that. Could it be their vision, their hearing, medication, physical discomfort? If the person has arthritis, if the weather's getting ready to change, some agitation or behavioral issues may be due to physical health and just being tired. Assign tasks. Okay, so there really are several steps to brushing your teeth. It's just that those of us that don't have a dementia, um, we have um, we have thinking skills. We have um, the ability to think abstractly. We have the ability to go and brush our teeth and not think about turning the light on in the bathroom, picking up the toothbrush, turning the water on, taking the cap off the toothpaste, squeezing the toothpaste onto the toothbrush, flossing first, bringing the toothbrush up to our mouth, brushing the front, the back, teeth, the in all of these steps, if you were to write them down, and if I was there with you, we would go through this activity. And what we would see is that there can be anywhere from 20, depending on how rigid you may be, to 50 steps. So as it relates to a person with dementia, you want them to remain independent. You want them to still be able to do things for themselves without taking over that task. But where you might be able to help is to break those steps down to the lowest, kind of the lowest denominator, and figure out what is it that they can still do versus where it is or what it is that I can do to help them. Because if the activity or the task becomes too complicated, they're going to get frustrated. There's going to be a mood change, perhaps. So, how can we break that task down? Remembering that we all have good days and bad days. Um, the person with dementia, Alzheimer's, is going to have good days and bad days. Memory and ability may range dramatically. It always seems to happen that, and families notice this. There's the primary caregiver caring for her dad, the female daughter caring for her dad, and somebody comes in from out of town that they haven't seen in years, and all of a sudden, dad seems as if there's nothing wrong for a while. You know, in a little bit, you'll begin to see some kind of a breakdown in their memory. But for some reason, for just a little bit, they can carry on a conversation. Their ability seems to be okay to where the family member that just came from out of town, they're like, nothing's wrong with him at all, but just give it time. Um, their reality may be different, remembering that they can't adjust, but we can. Remembering too that behaviors aren't deliberate. It can seem that way to families, that they are just purposely trying to make them mad or piss them off. But that's not true. Remembering and reminding them that this is a brain disease. So you can't take it personally. And reminding them, for families that have made a promise not to ever put mama, not to ever put daddy into a nursing home, and they feel guilty about it, sometimes they can be the most difficult families to deal with because of their guilt. So keeping that in mind, especially maybe for younger staff where this is their first time experiencing working with people with this dementia, that this is indeed a brain disease, and you're also dealing with some family dynamics. And we all know, well, if we tell the truth, not all of our everybody's family is a little messed up in some ways. And so you have to keep that in mind as you deal with families and helping them cope with their loved one. And sometimes it can brighten their day if you tell them how well their dad is doing or how well he did today, and just reassure him that it's your job to help take care of your dad, to help take care of your mom. And we got this, we can handle this. That's why you've entrusted your dad or your mom to be here. Daily struggles can be triggered by frustrating activities, using distraction and encouragement, personal preferences. This is where it comes to the person centered care piece. Dressing tips, allowing for independence, preparing for incontinence, um, you know, telling the person that they're wonderful, they're beautiful, and helping them look the very best that they can. Um, if there are some behaviors that are a little disturbing or that are sexual in nature, you may have to, informing the family about that, and sometimes not drawing attention to it. But if it comes to the place where it is harassing in nature, then you really have to care plan and come up with a plan to address that. And remember that in some cases, it is disease related. Hallucinations, increasing light, we talked a little bit about that. Sometimes um, asking the person about the hallucination. um, when I was a kid and having bad dreams, my tendency would be to go and try to get in bed with my dad and mom. So the reassuring that everything is okay, if they see, um, I have a friend who talks about seeing, monkeys with monkey pants on, help them talk it out, help them count the pink elephants that may in the room. But the reassuring part is to help them understand that they're safe, that you're going to be there to deal with something that they may view as frightening, and being patient, of course. Um, when it comes to redirecting, maybe sharing your experiences with childhood pets and their experiences, asking them where they grew up. Uh, if you know that the person's a farmer, talking about the farm, talking about the garden, talking about the chickens, again, about family members, and sometimes sharing information about your family. I don't know if you've had the experience where some of the residents want to know about you. They want to know a little about how you grew up, and a lot of some of the female residents love it when employees bring their kids up there. But certainly being aware of people that don't like children, that can be a little disturbing too. If you have a resident who was the neighbor who would tell kids, get out of my yard. So you want to make sure that you don't, you kind of know who you can bring your kids around and who you can't. Are there any questions at all? If I can hear you ask the question. So my email address and my cell number is listed on this slide. If you have any questions whatsoever, feel free to call, text, or send me an email. Um, I wish you guys well as you move through the process of becoming a licensed nursing home administrator. This is certainly a job that is needed and a job that takes training. Um, and it's not something to take lightly. And one thing that I would just kind of pass on to you is the importance of having trained staff and allowing your staff to be trained as much as possible. um, Taking care of your CNAs who really are the frontline workers. I also commend you all who are working in this age of COVID, taking care of yourselves, of course, and your families and your residents. So kudos to you as you pass along. And thank you for the opportunity. And you all, please drive safely as you go back to your own destinations. And who knows, maybe I'll see you around. All right.